¿Qué tal? Buenas tardes, es un honor para mí pues vengo de una conferencia magistral a la doctora Majella irlandés. Ella se entrenó en Irlanda como cirujana general y después se integró a los Estados Unidos, donde realizó un fellow de cirugía hepatopancreatular y cirugía de trasplantes en el Hospital Barnes and Jewish de San Luis, afiliado a la Universidad de Washington, Missouri, y actualmente es adscrita y profesora de cirugía de la Universidad de Washington. La doctora Doyle es una experta en trasplantes de hígado, trasplante pediátrico, y es una de las personas que más ha aportado a la literatura sobre el uso de las unidades de procuración, y actualmente también es muy activa en los diversos protocolos multicéntricos que hay de manejo con el carcinoma intrahepático, como lo van a ver en su plática, la cual va a versar sobre terapias avanzadas de carcinoma intrahepático. Bienvenida, doctora Doyle. Ojalá que la siguiente vez pueda ser presencial. Nos da mucho gusto tenerla en el Congreso. Adelante.
Good afternoon, everybody. I would like to thank the organizers for the honor of presenting to you all today. I'm going to talk about advanced therapies for intrahepatic cholangiocarcinoma. I have no disclosures. So today I would like to provide a framework for the overall oncologic principles guiding surgeons managing patients with cholangiocarcinoma. I'll review the definition of unresectability and provide an overview of current and emerging systemic regimens for this disease. I would also like to emphasize the importance of mutational profiling of diagnosis to guide treatment and inform treatment options, and review the spectrum of liver-directed therapy options, and then talk a little bit about the role of liver transplantation. Now, cholangiocarcinoma is an aggressive and rare cancer of the bile duct with a very poor prognosis. It accounts for approximately 3% of gastrointestinal cancers, but nearly 20% of deaths are from hepatobiliary cancers. Cholangiocarcinoma is also a clinically silent disease that presents at advanced stages. The epidemiology and rising incidence of biliary tract cancers is alarming. You can see here on the graph on the right that this is the numbers in the USA. The blue line is the overall, the light blue line is males, and yellow is females. And this is for intrahepatic cholangiocarcinoma specifically. This map just gives a global picture of some of the hotspots in the world in Asia, Australia, North America, and Europe. There are, of course, intrahepatic risk factors for intrahepatic cholangiocarcinoma, such as choledochal cysts, gallstones, PSC, and liver flukes. There are also other risks that are lower risk, such as alcoholic liver disease, NASH, and others. In general, most patients with biliary cancers have the best chance of cure with a liver and/or concomitant biliary tree resection with reconstruction. Liver resection these days is safe with a less than 2% 90-day mortality. The volume of resections the surgeon has performed is important, so it should be performed at experienced centers. However, only 10 to 20% of patients are resectable at the time of presentation. And because recurrence remains high, we are really not going to cure people with resections alone. Because many patients die from the burden of liver disease, we also need to think about intrahepatic therapies. The future will be integration of systemic and regional treatment with resection. Now, in this series, this landmark series by Dr. Tim Pollock and his colleagues looked at intrahepatic cholangiocarcinoma and described the current standards of care for patients with resectable disease to be resection with a portal lymphadenectomy, followed by adjuvant capecitabine for 6 months as established by the BILCAP trial. All major hepatobiliary organizations recognize that patients with multifocal disease should not be considered for upfront resection. Again, this emphasizes the importance of multidisciplinary approach and referral to a center. Now, what are we trying to achieve with intrahepatic resection? An Orzura resection leaving behind a well-perfused liver remnant with adequate biliary drainage. Remove the involved liver, perform a portal lymphadenectomy, remove or reconstruct areas of portal vein invasion, and perform biliary resection and reconstruction as needed. For patients with biliary tract cancers, referral to a HPB surgeon at the outset is ideal. We can divide the patients into two groups: technically resectable, as we just described, with adequate inflow, adequate outflow, and adequate future liver remnant, versus biologically resectable. And here we need to use our colleagues in oncology and other areas of expertise to help us understand the underlying tumor biology and give us the ability to achieve long-term survival and potential cure. Now, Dr. Skye Mayo kindly shared some of these slides with me on recently published referral patterns for intrahepatic cholangio and outcomes that they saw in Oregon. They saw a breakdown in referral reflected where patients did not have the benefit of seeing a HPB surgeon, or were told by somebody who'd never seen the liver that they had unresectable and incurable disease. In this paper, they looked at the Oregon State Cancer Registry on all incident cases of intrahepatic cholangio and demonstrated an association between increasing distance to a referral center and worse patient outcomes. Improved outcomes across the entire spectrum, including palliative therapies, were associated with any involvement of specialists. And interestingly, it was most notable when there was a combined management of the referral center with the community physicians. The impact of COVID on our health system has deepened our understanding of the importance of telemedicine and has allowed wider population access to specialists that were not available even 2 years ago. Access to a cancer center offering the full spectrum of available treatments and trials is essential to continued improvements in survival in rare cancers such as cholangiocarcinoma. Now, intrahepatic cholangiocarcinoma, mutational profiling. This is really the future for the management of this disease. When we profile intrahepatic cholangio, we see a myriad of mutations. Advances in next generation sequencing result in new first and second line treatments. For example, FGFR and IDH inhibitors for patients with these mutations are being used as second line treatments for these patients. Patients who have MSI high, they are being treated first line with checkpoint inhibitors. Patients with HER2 amplification are getting targeted with dual agent HER2 inhibition. And with the perpetuating continued analysis that were reported in this recent Nature review, just showed that the number of mutations and the number of potential inhibitors enhance the potential for new treatments for this disease. And it is likely that the molecular stratification of this mutationally rich set of cancers will continue. Now, this is a case also from Dr. Mayo, where a patient had a large tumor, biopsy proven as intrahepatic cholangio, was given 8 cycles of FOLFIRINOX as it was unresectable, involving hepatic veins and vascular structures in the porta hepatis. When they biopsied the tumor, however, and did molecular profiling, they found that the patient was positive for microsatellite instability. The patient had 12 cycles of checkpoint inhibitor, pembro, and had a fantastic response. The patient then went on to have a liver resection, and in fact, the liver had no evidence of tumor and had shown a complete response. Begging the question is, did the patient even need surgery? These are answers that we need to come up with, and these are answers that we cannot answer currently. So what is the current status of neoadjuvant therapy for patients with intrahepatic cholangio? Well, we really don't know. It's a rare disease and trials are hindered by small numbers. It takes a long time to accrue patients, and with The trials that have been done in metastatic disease, it's taken 4 years to accrue, 3 to 5 years of follow-up, and 1 year to publication, results in a decade lag extrapolation of data to patients with resectable disease, which is unhelpful. Now, Dr. Shisher-Mathel and colleagues have taken on this challenge and have performed a single-arm phase 2 study with to assess the feasibility of neoadjuvant therapy with gem, cis, and paclitaxel for patients with technically resectable but oncologically high-risk intrahepatic cholangio. The secondary objectives to evaluate resectability rates, recurrence-free survival, and overall survival, and to correlate blood and tissue biomarkers with response to chemotherapy, recurrence rate, and overall survival rate. They have just finished accruing, so more to come with this multi-center study. In addition, Dr. Mathel has put together the OPTIC trial, looking at patients who are potentially resectable with FGFR2 fusion. The primary outcome, again, is feasibility, and the secondary outcome is response to therapy and recurrence-free survival. And this is an 8-center trial. Again, the results to be determined. So, in summary of immunotherapy and adjuvant and neoadjuvant therapy, there are many emerging therapies. Neoadjuvant therapy with GAP, we're awaiting the results. Identification of biomarkers for the selection of patients harboring pertinent genetic aberrations is an essential factor in targeted therapy. Future trials, patients should be stratified according to disease subtype and genetic drivers. The extensive interactions and crosstalk between the various signaling pathways involved in cholangiocarcinoma carcinogenesis highlights the importance of combination therapeutic approaches. In particular, the combination of molecular targeted agents and immunotherapy with immune checkpoint inhibitors merits further investigation. And so from this review, they're talking about the combinations of molecularly targeted agents and immunotherapy. However, I believe that there's more to this combination. If patients with intrahepatic cholangio are eligible for resection, then resect and give systemic therapy. That's the current regimen. However, if they have high-risk disease, consider neoadjuvant therapy followed by restaging and resection. But what do we do with the 70% of patients who are diagnosed with intrahepatic cholangio that are not resection candidates? What are their treatment options? Let's think about local regional therapy. So why is it attractive? The tumors usually derive their blood supply from the hepatic arterial system. So therefore, you should be able to get to them through this system. Several modalities can be used that target the liver and spare systemic toxicities, such as Y90, stereotactic radiation, TACE, and hepatic arterial infusion pump. Now, this is a study from 2013, looking at TACE and Y90 and showing a median overall survival of about 13.2 months, with a 1-year survival of 54%, but a 5-year survival of 16.2%, and no real difference between the therapies that were used. This led to the MISPEC trial, which was published in JAMA Oncology in 2020. And it's looking at radioembolization plus chemotherapy, so combining local regional therapy with systemic chemotherapy for first-line treatment of locally advanced intrahepatic cholangio. It's a phase 2 prospective open-label multi-center trial evaluating Y90 combined with gem-cis therapy. Primary objective to look at the response rate at 3 months as measured by RECIST, with a secondary objective looking at toxicity, progression-free survival, overall survival, and disease control rate. 41 patients were included in the trial, and this graph shows the response rates. The response rate was 39%, and 22% of patients were downstaged to surgical intervention. Their secondary endpoints showed that their median overall survival was 22 months, and the median progression-free survival was 14 months. Combined immunotherapy and Y90 has also been examined in some pilot studies and show by combining radiation therapy with checkpoint inhibitors that we're seeing an even further response to local control and an increased rate of durable immunotherapy responses within and outside the liver, which is very interesting, leading to the consideration that combining Y90 and checkpoint inhibitors can even have a more synergistic effect. So in summary, for interventional therapies, it seems that combination therapy is safe and effective, response rates are good, and so there is some conversion to resection. Addition of local regional therapy seems to prolong progression-free and overall survival, but further trials are needed to understand the optimal timing of combination therapies and the immune therapy environment after Y90. This brings me to discussing the hepatic arterial pump infusion for unresectable or multifocal intrahepatic cholangio. Based on higher liver extraction of FUDR versus 5-FU during intraarterial therapy and first pass metabolism, the intrahepatic arterial pump has been used most commonly for colorectal metastases treatment. For those of you who aren't familiar with it, it's a pump about the size of a hockey puck that's placed in a subcutaneous pocket. A catheter is passed into the abdomen and the gastroduodenal artery is dissected out. The catheter is placed in the gastroduodenal artery, the chemotherapy is placed into the pump, and it delivers chemotherapy directly to the liver. And it can be used in combination with systemic therapy. Now, we have had a long, strong interest in using the pump both for colorectal metastases and in intrahepatic cholangio. And in conjunction with Memorial Sloan Kettering, where the technology was developed, we performed a phase 2 clinical trial with 38 patients with unresectable, non-metastatic intrahepatic cholangiocarcinoma, with a median follow-up of 30 months. And here are some of the results. We found a 58% response rate and 84% disease control at 6 months. 4 patients converted to resectable tumor. 1 of those had a complete pathologic response. The median progression-free survival was actually 12 months, and the median overall survival was 25 months. The toxicities were manageable and tolerable. When we looked at molecular tumor analysis, we found that patients with IDH1 mutated tumors had improved overall survival with a 2-year survival of 90% versus 33% for the other mutations that were seen. And here's a case highlighting this. With a 60-year-old female who presented with abdominal pain, 10-centimeter tumor, IDH1 mutation, and microsatellite stable. Patient has a pump placed. You can see here is a big tumor and several satellite lesions, many of which are not seen on the scan. She gets 12 cycles of FUDR via pump and systemic GEM-OX. She has an excellent response to therapy, and she undergoes an extended right hepatectomy because her segment 2-3 was free of disease, bile duct resection and reconstruction. The tumor showed 80% necrosis effect, and the patient did well postoperatively. She did have adjuvant therapy for 6 months postoperatively with Xeloda and gemcitabine, completed in April 2018, and the patient is doing well. Further interest in this combination using the hepatic arterial pump has been taken up by our colleagues in Portland, and they are performing the HELIX trial, a phase 2 trial for unresectable intrahepatic cholangiocarcinoma, and they are combining FOLFIRINOX with the hepatic arterial pump infusion. They are excluding patients who have had prior Y90 or XRT, but most other patients are included. Now, finally, let's talk a little bit about intrahepatic cholangiocarcinoma and the role for liver transplantation. Why is it attractive? Orthotopic liver transplantation may override positive margin concerns for unresectable disease. You take the liver out, there's little chance for a positive margin. Initial experiences in the 80s and 90s, however, were poor, with a 50% recurrence rate and 30% overall survival. Current practice is limited to a few high-volume centers. In 2014, the Journal of Hepatology, these guidelines were published from the International Liver Cancer Association for the Management of Intrahepatic Cholangiocarcinoma. And as you can see on the table, there's really no mention of liver transplantation. For patients with unresectable disease, it's local regional therapy, chemotherapy, and with a poor median survival of 15 months to 12 months. They specifically recommend that liver transplant is not recommended for intrahepatic cholangio or mixed HCC intrahepatic cholangio because results are well below those published for standard indications. However, this recommendation is based on limited data. Future studies should focus on standardized selection criteria plus adjuvant and/or neoadjuvant therapy with liver transplantation as definitive therapy for intrahepatic cholangio. Now, in 2016, Gonzalo Saposocian from Toronto, on behalf of the International Consortium for Intrahepatic Cholangio, performed this multi-center prospective assessment, a retrospective assessment of very early intrahepatic cholangiocarcinoma. And they found that the actuarial survival and the cumulative risk of recurrence was very good in very early intrahepatic cholangiocarcinoma patients. These are patients who had less than 2 centimeter sized tumors. None of them had had pre-TACE, and only a third of them had had ablation preoperatively. The advanced group, however, did more poorly, both on the survival spectrum as well as the recurrence spectrum, leading to the conclusion that liver transplantation for very early intrahepatic cholangiocarcinoma is reasonable, with a 5-year recurrence rate of 18% and a 5-year survival of 65%. An earlier study did give some glimmer of hope, showing on the solid line here that survival after liver transplantation is significantly better than after resection. Now, this study did include hilar as well as intrahepatic cholangiocarcinoma, but still interesting nonetheless. We performed a multi-center analysis of liver transplantation for combined HCC cholangio liver tumors, and it was presented at the Southern Surgical last year. We demonstrated that overall survival and disease-free survival in patients who had tumors within Milan criteria had the same rate of overall survival and disease-free survival as patients with HCC. And to take it a step further, the group in MD Anderson and Methodist, and these slides are courtesy of Dr. Mark Gabriel, took it to the next level, looking at giving patients who are unresectable neoadjuvant chemotherapy, first line with platinum-based therapy and gemcitabine, second line chemotherapy for progression or intolerance, and addition of targeted biologics on a case-by-case basis based on the mutational profiling of the patients, giving more weight to the fact that combinational therapies are the way forward. Patients who had disease stability for at least 6 months on the given regimen with repeat imaging every 3 months were listed for liver transplantation. Post-operatively, they were treated for 4 to 6 months, depending on explant pathology. So the number of lesions that patients had, the median was 2, the maximum size was 7.4, and the total tumor diameter was 10.4 centimeters. Here are the results. When we look at patient survival, patients had over 80% overall survival. Now, their recurrence-free survival did drop off some. These are representing 3 patients who recurred, giving an overall patient survival of 50%. When you look at overall survival in those transplanted versus those not transplanted, it's pretty remarkable. The ones who were transplanted have over an 80% survival versus the ones who are not transplanted, who will all die within 18 months of their disease. And this is some of the data of the 9 patients that at the time were transplanted, with some significant time out, 5 years, 3.5 years, 3 years, and then some months. Now, I'm not suggesting that we transplant everybody by any means, but I do think that it has a role, and there's probably some very select patients who may benefit from transplantation. And this is one example, a 64-year-old female who was found to have an IDH1 and KRAS mutation and a 9.8 by 6.3 centimeter tumor that was unresectable right in the center of the liver. You can see here this ugly, typical intrahepatic cholangiocarcinoma. She initially had a pump placed and a portal node dissection. The pump was given, she was given pump therapy for 3 months along with systemic GEM-OX. An MRI after 3 months showed no change in size and persistent encasement. She then underwent radioembolization with Y90. This resulted in some shrinkage of the tumor along with reduced enhancement, showing some good tumor effect. She was also given treatment for her IDH1 mutation at this time. However, sometime after this treatment, she developed signs of liver failure with worsening ascites. She found us and our interest in intrahepatic cholangiocarcinoma. Given her tumor at this stage was 18 months after her diagnosis, was quite stable, had no evidence of enhancement, we went ahead and considered her for transplantation. 19 months after her diagnosis, she was listed, and 21 months after diagnosis, she was transplanted. She was transplanted with a discarded liver on our RESTORE trial, which we can get into in the discussion if you would like. This is using discarded livers with normothermic liver perfusion. This is a scan pre-transplant. And this is her scan 28 months after diagnosis, 6 months post-transplant. The pathology demonstrated no evidence of disease, and she continues to recover. She's more than 8 or 9 months out from her liver transplant at this point. Our current experience with liver transplant for intrahepatic cholangio includes 7 patients, so very small. The tumor numbers range from 3.5 to 6.5 centimeters in size. We haven't shown any difference in survival between HCC or combined hepatocellular HCC, but again, the numbers are small in both, with 18 combined HCC cholangios and 7 pure cholangios. So we developed this protocol at Washington University for intrahepatic cholangiocarcinoma, thinking about liver transplantation. So patients with unresectable disease who are biopsy proven have had suitable treatment, systemic chemotherapy, along with some liver-directed therapy, radioembolization, hepatic arterial pump infusion, or external beam radiation therapy. And of course, they need to be medically suitable for transplant. We are doing cell-free DNA on all the patients before and after transplant, and obviously getting full molecular profiling on all of these patients. So in summary, intrahepatic cholangiocarcinoma is a very challenging disease. Multidisciplinary involvement, including an experienced hepatobiliary surgical team, is essential to optimize treatment, sequencing, and options. Mutational profiling should be done at the outset, and its importance will only increase in the coming years. The treatment teams for this rare disease need to have a full understanding and ability to offer the entire spectrum of treatment available, including expansive regional therapy programs that will likely include liver transplantation for selected treated patients. Thank you very much.
Three, two, one.
¿Qué tal? Buenas tardes. Estamos de regreso a esta mesa redonda.
Hello, good afternoon. We're back here in this round table. We would like to thank Dr. Doyle for her excellent presentation and thus news of the treatment that has changed in the last 5 years. And we also have Dr. Martinez Mier, who is a transplant surgeon from Veracruz, and the both of us will be coordinating this roundtable, and of course that will present the questions that you ask us in the chat. I'd like to start with a question for Dr. Doyle. I believe that in the intrahepatic procedure, what's happening is very similar to the neuroendocrine situation where we are not very clear on the best sequence. Even though we have more options, we do not know the best sequence to start. So what would be your recommendation regarding the advanced treatment strategies that would be ideal, and what would be the first step that you advise as the first one between the arterial pump, lithium, or biological treatment?
Thank you for the question. Thank you, everybody, for listening and for inviting me for this panel today. So I think it's a great question. I think it's difficult for us to know, really. The intrahepatic arterial infusion pump, I do feel that may have an edge over the Y90 radiation treatment, but you know, it's very complicated to get a program going that has a hepatic arterial pump infusion. You need a really invested team around it. And it's not convenient for many of the patients because they have to come every 2 weeks to a month, depending on what pump you're using, to have it refilled. So it doesn't work for all patients by any means. The Y90 in many ways is a cleaner treatment because it's one treatment, usually, sometimes two. And, you know, I think, and obviously both are given in combination with systemic chemotherapy. It seems from the very small trials that have been done that maybe the pump is slightly better than Y90, but I think the key is that the investigational trials going forward really need to incorporate combination therapy, because I think that's going to be the key going forward. We're not going to cure anybody with pure resection. We're not going to cure anybody with chemotherapy or Y90 or the pump alone. I think it's going to be combinations of these, and there are some great trials ongoing that I think will help answer some of these questions. So as of now, I think it's a convenience, and if the program exists, we will think about pump for the patients if they have no metastatic disease. If they have challenges with the pump, or they can't get to the pump, or they're not interested in the pump, then we would do Y90 along with systemic chemotherapy for both. That's our current practice.
Gracias, doctora Doyle. Gustavo, ¿quieres hacer alguna pregunta?
Thank you, Dr. Doyle. Would you like to ask any question, Gustavo? Well, hello. It's a pleasure to meet you and greet you. I want to thank you for this wonderful presentation. And my question is focused on, well, it's clear to me that the strategy in the case of the liver transplant with the carcinoma is somewhat controversial. There have been many evidences that go one way or the other. So what's your very personal thought or point of view regarding this, and could you maybe highlight the experience of your center in terms of transplantation in this pathology?
Thank you for the question. So I do believe that there is a role for liver transplantation, but it's going to be very select few patients, just as it is for hilar cholangiocarcinoma. Many patients we may consider for transplantation as we move forward in the future, but I think still it will only be a small percentage that will make it without developing metastatic disease. And I think giving these patients the biologic test of time will help us determine some of these patients. I also think the molecular analysis of these patients is very important, because as time goes on, we're probably going to find some patients will do better with transplantation and some will do worse. For example, the response with the pump was much better in IDH mutated patients versus those with other mutations. So I think that's a very key factor for going forward. Now, in our institution, we've transplanted only 7 patients with pure intrahepatic cholangio, and I think we've transplanted about 20-something patients who have mixed cholangio HCC. And what we're moving towards now is getting patients ultimately treated with either Y90 for the most part, because a lot of the patients we see may have cirrhosis when they have smaller tumors, but these bigger tumors that we're seeing, along with the MD Anderson idea of treating these bigger tumors with neoadjuvant therapy, we are trying to treat the tumors with systemic neoadjuvant therapy and either use Y90 or the pump to really kind of treat those tumors, and then think about liver transplantation in those that have been completely treated and have had at least 6 months of disease control or response, and then considering transplantation. That's our protocol at the moment. We've only done, I think, 3 patients under this protocol. So again, it's very going to be very small numbers, and it's going to take a while to kind of see exactly where we are.
De las preguntas del auditorio, tenemos...
From the questions of the audience, we have one from Dr. Daniel Zamora, a transplantation surgeon. He's asking you, Dr. Doyle, traditionally, the transperitoneal biopsy has been the contraindication to consider cholangio patients for transplantation. Would you consider the transperitoneal for patients with intrahepatic carcinoma that could be candidates for transplantation?
Yeah, I think that's a great question. You know, we've certainly tried to avoid any EUS type biopsies of any hilar tumors for the same reason. And we certainly, if we have control over the biopsy of the patient, we would advocate for the biopsy to be done through healthy liver. So in other words, you're biopsying through the skin, through the liver, taking tissue from the tumor and coming back out through the clean liver. And we haven't had issue with that. Similarly, with patients who might need PTC drainage, and this is more for hilar patients, we also, it's not ideal, we don't favor it. But if the patient has a PTC, as long as it's not going directly into tumor, we are okay with that. But it's something that we have to consider. All of these patients who are being considered for transplantation get multiple diagnostic laparoscopies. They have EUS with biopsy of their nodes, much like the hilar cholangio patients that we've kind of had protocols in place for a lot longer. But I think the peritoneal spread from a biopsy would certainly, I would hope, be evident on laparoscopy, but we would certainly try to avoid going directly into the tumor.
Gracias, doctora. Gustavo, ¿tienes alguna pregunta?
Thank you, doctor. Do you have any question, Gustavo? Well, I would like to ask you, Dr. Doyle, given the good results or promising results of the phase 2 multi-center study of the intra-arterial pump in hepatic carcinoma, we would like to think that this could also be a strategy as an adjuvant treatment. Is there any experience or any clinical trial already being done regarding adjuvant treatment of intrahepatic carcinoma? There is a lot of literature as adjuvant treatment in colorectal cancer. So what about this?
Another great question. And so, you know, Memorial Sloan Kettering had a trial a few years ago looking at adjuvant therapy after resection, and we actually enrolled a patient in it. And then the trial, I think it was just so slow to accrue patients, they decided not to go to continue with it, and they stopped it. So I'm not sure, there hasn't been anything else done trial-wise for adjuvant therapy with the pump. One of the slight concerns, I suppose, is oftentimes these patients have a very large resection for these, particularly for larger intrahepatic cholangios. And Personally, I'm a little bit wary of using the pump when the liver future liver remnant is very small. Our colleagues at Memorial have such great experience with the pump. They really know what the limitations are. But I personally worry a bit about it in the adjuvant setting. But I think it's doable. I just don't think there's any real data on its use.
Gracias, doctora. Hay otra pregunta.
Thank you very much, doctor. There is another question from Dr. Daniel Zamora regarding the lesions, the satellite lesions. Usually cholangiocarcinomas have more than one lesion. Would you differentiate among the satellite lesions or intrahepatic metastasis to consider them candidates to transplantation?
So this is definitely a challenging area. And I think when you have multiple satellites, the evidence is clear that these patients should not undergo resection, even if they're resectable, at least at the outset. And they would be considered in the high-risk group that Dr. Mathel and his colleagues are planning to look at in the neoadjuvant GAP phase 2 trial that they're running. And so we have had a few patients, in fact, we resected one just very recently that had no disease in segment 2-3, but had a big tumor in the right lobe with multiple satellites. That patient had Y90, had some external beam radiation as well as systemic therapy. And there wasn't a mutational action, but again, getting a mutational analysis, because as you can see from the case that I presented at the beginning, there's quite the response to therapy if you get one of those actionable mutations, which makes a big difference to the patient's treatment. So satellite lesions, very high risk, much higher risk than a single lesion. So if you can do adjuvant therapy, I would. And these are patients that if we see them first before they have Y90, which often doesn't happen, we would certainly put a pump in these patients if they were willing to go forward and use systemic GEMOX along with it.
Gracias, doctora. Quisiera también preguntarle.
Thank you very much, doctor. I would also like to ask you if there are any technical implications of difficulty at the moment of the transplantation because of the prior use of Y90 or the intra-arterial pump.
Yes, very good point. I'm glad you brought that up. It is very difficult, particularly after the pump. And it's not from the previous surgery of putting the pump in, but I think the chemotherapy running through the hepatic artery causes a lot of inflammation in the porta hepatis, and it can be extremely challenging. So you certainly need to make sure that you have vessels on standby. And when I've done these transplants, I've taken my inflow from the splenic artery, if it's healthy, rather than using the hepatic artery, as I worry about a pseudoaneurysm or a clot after transplant. Y90, I find not as bad in the porta if the tumor is not right centered in the porta. If it's centered in the porta hepatis can also be very sticky. But if the tumors are more in the body of the liver, then I find the Y90 causes stickiness to the cava or stickiness to the diaphragm, depending on where the tumor is located. But definitely can be challenging. And the same goes for resecting after these cases too. They can be extremely challenging.
Gracias, doctora. Gustavo, ¿quieres hacer
Thank you very much, doctor. Would you like to ask any other question, Gustavo? I would, yes. I'm sorry, I lost the camera for some time. I apologize. However, my final question, well, it would actually be a recommendation for local level regarding what to do, not only for HPB surgeons, but also for general surgeons, because many are probably watching the Congress, and also a doctor could tell us about this. If we do not have the possibility of measuring the mutations, then simply to try what would be your opinion? To try resection whenever possible, to refer them to a transplantation center, or what would be your recommendation in case we don't have all this technology available?
Well, interestingly, I think it's worth getting an opinion. And one of the things I think that the pandemic has taught us more than anything is, as we are here now, being able to Zoom and look at films are really important. And so perhaps if the patient is in an area that's not convenient to a local HPB expertise, And they certainly doesn't need to be a transplant center. I think a HPB surgeon would be the person, or a transplant surgeon that does HPB. But I think these patients do better. And this was a paper from Portland, Oregon, that I showed in the talk earlier. If you refer a patient, whether it's virtually or in person, but that patient still gets treated in the community, they actually do better than being treated in the community or being purely treated at a HPB or transplant center. So I think there's advantage in getting a second opinion for these patients. I think a lot of the time decisions are made on some patients where an oncologist will just see the patient and go, oh, there's nothing that can be done, just chemotherapy. And that might be doing a disservice to the patient. So getting an opinion from an expert, whether it's by sending a video of a scan to an expert, asking an opinion, I think is very helpful. And yes, of course, if the molecular structure can't be obtained, you know, there's neoadjuvant therapies with GemOx or GemCis that can be, an even gap could be used. But I think a discussion, at least with somebody who's in this area of expertise, is very helpful. And I think that's a message that would be nice to get through to the oncologists, because I do feel both all over the United States and Canada that there are many oncologists who will just see these patients and just go, oh, there's nothing we can do. And that's not always the case.
Thank you very much.
Doctora Doyle, el doctor
Dr. Doyle, Dr. Carlos Rodriguez Montalvo, who's also a transplantation surgeon from Mexico, is asking us how you assess peritoneal disease in patients that are suggested for neoadjuvant chemotherapy.
If in these high-risk patients, if they have a very high CA19-9 or multiple satellite lesions, we will sometimes do a diagnostic laparoscopy on the patients beforehand, but we don't always. I would say many of the times the patients have had neoadjuvant therapy with the oncologist before we've seen them. And if they haven't, we may discuss it at multidisciplinary conference. And if everybody feels strongly at the multidisciplinary conference, we will do a diagnostic laparoscopy. But that's really the only way we have found to be successful in diagnosing peritoneal disease. Most of the patients will get a PET and get a chest CT, and obviously get an abdominal MRI or triple phase CT. So I think adding diagnostic laparoscopy there can be helpful, but probably just in high-risk patients where you really have a high suspicion for peritoneal disease. Although I have to say, I see it less in these patients, but we do see it occasionally where you just have this one tiny little nodule that's located on the peritoneum that would be impossible to see on any other imaging.
Doctora Doyle, en estos casos, por ejemplo, que cumple...
Dr. Doyle, in those cases, for instance, that comply with the criteria for liver transplant, and in the OR you find a node that is suspicious in the ileum or a peritoneal area that is resectable, would you suggest continue with the transplantation or just suspend it?
No, if we bring in a backup for anybody who's coming in for transplantation, and we send lymph nodes from the operating room once we open. And if they come back positive, we'll abandon the transplant. And the patients are all consented to know that beforehand. And it's the same, we do the same for hilar cholangio also.
Okay, gracias, doctora. Otra pregunta.
Thank you very much, doctor. Another question. Currently, we have many groups in Asia, particularly China, that have published promising results in the treatment of intra-arterial hepatic treatment in hepatocarcinoma. So this would have an implication in the change of biphasic tumors, hepato and cholangio?
Like the biphenotypic tumors? Yes, you know, and I think these are less well studied. Many of these biphenotypic tumors get transplanted when they're small accidentally, thinking that they're HCC. We published a multi-center trial recently, the end of last year, looking at biphenotypics from, I think, about 12 centers. And we found that for the patients who are within Milan, The biphenotypic tumors do just as well as those who are just pure HCC. In patients who are beyond Milan, they do slightly worse, but they still do significantly better than patients who were just treated with local regional therapy. So I think if we can get these patients with biphenotypic tumors to transplant, they will do very well. But not everybody is going to make it. I think that again, you're going to have some patients who are going to progress and not be suitable for transplant. I think that's what you asked me, Ishmael.
Sí, doctora. Gracias.
Yes, doctor, thank you. Gustavo, do you have any other question for Dr. Doyle? No, I'm fine. I think his microphone is off.
Ishmael, we can't hear you, you're muted.
Perdón, el doctor Zamora pregunta.
Sorry, Dr. Zamora is asking if the mutational profile and the response to treatment with chemotherapy in adjuvant could maybe define those patients that are candidates for transplantation.
I think it will in the future for sure. I think we don't have enough information yet, and there hasn't been enough patients transplanted, and we won't transplant anybody who's not had a significant response to therapy, no matter what. We're considering patients who are having systemic chemotherapy plus some sort of local tumor therapy, and then a test of time. But I think the mutational analysis is going to become important. And as I mentioned earlier, the IDH1 mutation, for example, fared much better after in the hepatic arterial pump infusion trial compared to some of the other ones. They had like an overall 2-year survival, I think, of 90%, which is pretty remarkable. So I do think the mutational analysis is going to become more and more important in the selection of these patients.
Otra pregunta, doctora.
One more question, doctor. Well, there's a lot of optimism regarding the use of those treatments that are guided by the mutational profile, not only in cholangiocarcinoma, but other oncology pathologies. But how much patients, at least in St. Louis, can receive those treatments that are extremely expensive? In Mexico, it's very difficult to be able to provide this kind of treatments to a patient, but how much are you achieving insurance companies to cover for this?
Yeah, I think it's very challenging also. And I think the oncologists have to fight sometimes with the insurance companies to get approval. And certainly, patients with limited coverage are going to be limited to get these drugs. So it's very challenging. But I think, as they become more and more, as we treat more patients and we can show that the patients are doing better, I feel like with other chemotherapy drugs in the past, that when they were new were very expensive and very difficult to get, they become more mainstream as time goes on. It's just you feel bad for the patients who don't have access to them in that time period. It's kind of like, for example, we're transplanting patients for colorectal metastases on a very limited case-by-case basis. And many of the insurance companies, certainly if you have Medicare, they won't pay for the transplant, and these patients won't get access to transplant. Yet, we're showing with a very small cohort of patients that they do well. But this is another challenging area. Getting things paid for is very difficult.
Doctora, ¿cuál es su opinión respecto a los tumores?
Doctor, what's your take on intrahepatic carcinomas with vascular invasion?
Well, again, I think it's
surgery. Sorry, you kept talking.
Sorry.
But
what is the oncological implication of patients with cholangio with a cava invasion, for instance, that would technically be able to reconstruct? So would it be worth it to subject the patients to potentially morbid procedures, or would it be better to be more cautious?
So are you saying if the cava is involved that we should go ahead and resect the patient? Is that what you're asking?
Correcto.
Right.
I think I mean, certainly we would, if the patient is very high risk, if there's tumor thrombus, we would probably treat them first, again, similar to, multiple satellite lesions. So we would use systemic therapy and maybe a Y90 or a pump. But I have to say, and I have a case actually on next week where there's some tumor in the right hepatic vein, tumor thrombus in the right hepatic vein. And we discussed this lady, she's a 10-centimeter tumor, but she's resectable with a right hepatectomy. And having discussed it at our multidisciplinary conference, because there's really no good data on the neoadjuvant therapy, I think if the patient is resectable and you can do it with a vascular resection or whatever you need to do, I still think for now, that's the best result with adjuvant therapy, unless you have a molecular target that you can use, either a checkpoint inhibitor or FGFR or IDH1 inhibitors.
Muy bien, muchas gracias, doctora.
Very well, thank you very much, doctor. I don't know, Gustavo, if you have any other question. I don't think we have any more in the chat. No further questions. Yes, indeed, no further questions. So, no, actually, I would just like to thank Dr. Doyle for her time, her patience, and the opportunity of hearing such interesting concepts from her. And once again, to consider that transplantation is not as easy as it seems in this pathology that is extremely complicated. And we realize that expert hands and multidisciplinary management have to be clear and are essential, and the infinite value of surgeries, as she herself mentioned, in cases that involve vascular areas or other situations. So I would just like to summarize everything and thank her for her awesome, fantastic presentation.
Well, thank you very much, and thanks very much for this great discussion. I've really enjoyed it, and I will say one thing: I do believe with Zoom we have a great opportunity as surgeons to be able to get together more frequently and and discuss these challenging cases when the expertise is not totally available locally. So, thank you again.
Doctora Doyle, muchas gracias por su participación.
Dr. Doyle, thank you very much for this participation. As always, it's a pleasure to hear you and see you. And we thank you for being with us this Friday afternoon. And thank you very much. And greetings at home. And with this, we would end this module of Intra-Hepatic Cholangiocarcinoma. Thank you very much for everyone who logged in and ask questions, and we'll continue the Congress with what's coming next. Thank you very much. Good evening. Good evening, Gustavo.